ALS and me. I have lived with ALS, or Lou Gehrig's disease, for 5 years now. ALS stands for amyotrophic lateral sclerosis. According to the ALS Association, it is a progressive neurodegenerative disease that affects nerve cells in the brain and the spinal cord. Motor neurons reach from the brain to the spinal cord, and from the spinal cord to the muscles throughout the body. The progressive degeneration of the motor neurons in ALS eventually leads to their demise. When the motor neurons die, the ability of the brain to initiate and control muscle movement is lost. With voluntary muscle action progressively affected, people may lose the ability to speak, eat, move and breathe on their own. If a ventilator is not used, the patient will die of respiratory failure. ALS is a terminal disease. Every victim has experienced fasciculations, uncontrolled muscle twitching. These alone, in some cases, are benign, but when this phenomenon is followed by muscle weakness, it raises a red flag toward a diagnosis of ALS. In fact, the first symptom which presented itself to me was severe twitching in my left index finger. I thought I was cool. I thought I was special. It was the perfect conversation piece at parties. Well, I'm glad you're doing well in the stock market, and your 401k is at an all-time high. You must be very proud. I'm bored with the gentleman at this point. Spotting my wife, rolling my eyes, then I asked the man with all the enthusiasm I can muster, "Hey, looky here, can your finger do this?" "No, don't pull it, just watch." Oohs and ahs emanate from the crowd. Everybody looks at each other amazed. Then they finally break down into a glorious round of applause. I'm so overcome by emotion that I have no choice but to take a bow. Little did I know what this simple tremor in my finger would lead to. I did have a premonition that something might be wrong. When I received a concussion after I experienced several falls, I knew a serious problem existed. So, began a long, tedious road to a diagnosis. It took 8 months before I received the news. No test exists for sporadic ALS, the type of ALS I have. Consequently, the journey then becomes a lengthy process of elimination. Are there any tumor, lesions, or abnormalities in the brain? No. Are there any irregularities in your spinal fluid? No. Could you have any heavy metal present which could result in neurotoxins attacking your brain? No. Do you have Lyme disease? No. Is there any delay in the speed of the signals your motor neurons are sending to the muscles and nerves? Yes. Are you experiencing fasciculations and weakness in your muscles? Yes. The neurologist comes into the room and says, "Mr. Jackson, there's a strong possibility it is ALS. There is no cure." Silence. I'm searching the good doctor's face for any sign of compassion. Nothing. Life expectancy with your disease is 3 to 5 years. Now, do I get any sympathy? The neurologist's expression does not give, "It is as cold as the grave I'll be buried in." I'm thinking, seriously, is that it? Have you nothing more to say? The doc could have at least offered me a stick of juicy fruit or even a breath mint. A tic-tac, perhaps? Alas, it was not to be. Instead, I got stuck with a bunch of pamphlets about ALS, stuff I knew by heart from extensive internet. Oh, for me. A bunch of useless pamphlets. You shouldn't have. Thanks anyway. Look, doc, shake my hand, look me in the eye and tell me, good luck with that, Mr. Jackson, rather than wasting all your money on these dreadful handouts. Save a tree or two. It will have more of a positive impact on humankind than how you just treated me. We need to bridge this gap of bad doctor-patient relationships. I think doctors should start offering the patient a voucher for 1 free chocolate pudding from the hospital cafeteria upon receiving a diagnosis of a terminal disease. Whipped cream will cost you extra, though. What do you mean there's a strong possibility that I may have ALS? Remember, a test for ALS hasn't been established yet. This possible diagnosis was hard for me to accept. I'm an analytical guy who lives in a world where only 2 answers exist, the right one and the wrong one, to examine all the evidence to back up their assertion, especially if it concerns me. The neurologist presented the news to me without collecting all the information. Since there are several ailments that mimic the symptoms of ALS, I think the doctor should leave no stone unturned before concluding that I have a terminal condition. A lumbar puncture to analyze my spinal fluids was not performed. I was not pleased. Immediately after leaving the office, I scheduled an appointment to get a second opinion. The second neurologist did thorough medical workup including the lumbar puncture. The results were negative. No abnormalities were present in my spinal fluid. And for the second time, I was told the date appointed to me having ALS. No worries, first neurologist, the joke's on me. I was the one who chose to endure the second battery of tests just to be told the same thing. Every single day proves your educated guess was proven correct, as I am now totally paralyzed, tube-fed, tracked, and ventilator-dependent. But your hypothesis won't be confirmed until an autopsy is completed on me. Accepting the second opinion was less of a problem than I thought it would be. My attitude was more like, okay, so, I have ALS. What now? I already had gone through the deep depression by this point. So, how do I turn this situation around for my family and me? I refuse to let this disease get the best of me. I agree with Dylan Thomas, my favorite poet. I will not go gently into the good night. I will rage against the dying of the light, and be the most stubborn, salty bastard this disease has ever seen. Thomas, 1938. Don't get me wrong. Depression would rear its ugly head over the next year as I would watch my body deteriorate before my eyes. Progression was quick and ruthless, showing no signs of stopping until it had taken all movement from my body. And the proverbial cherry on top was the fact that I was ventilator dependent by the end of the year. When I started researching what I could expect from this disease, I watched numerous videos on the internet about people who have ALS. These short documentaries scared the hell out of me. The videos play this hideous sappy background music filled with sorrow and despair. They define what ALS is and tell us a little bit about the doomed victim, their age, first symptoms, date of diagnosis, etc. Next, the video will digress into a conversation about dealing with ALS. This part is accentuated by somber interviews with caregivers and family members, usually in tears, discussing how hard it is to see the patient wither away and die. Some videos go no further. But, if they really want to terrify us, they will include more footage of their ultimate demise. We will see pictures of the emaciated patient staring into the camera through hollow, lifeless eyes. I fell for it at first. Then, I was watching TV one night, and I made the connection. These videos are no different than those rescued animal commercials. Conclusions I have made from watching these pound puppy videos are: 1. This is not the image I want to project to the world. I will never make one of these videos. And 2. I would rather my wife leave me hanging naked in the Hoyer lift with my butt slathered in bacon grease over a pack of hungry raccoons than sit through another one of these negative videos. I have ALS. Bear with me for just a moment, and let's analyze the previous sentence. The first couple of months after my diagnosis, I formed the nasty habit of saying I have ALS. It didn't take long for me to start hating this sentence. To me, it means I have surrendered to the disease, that I have rendered myself dormant as ALS consumes all of me both mentally and physically. Okay, good doctor, you're telling me I only have 2 to 5 years to live. Screw you, I'll show you a little something about the human spirit. Oh, you say my quality of life will deteriorate if I get a trach? Screw you twice. Sit back and watch me live a fulfilling life. Maybe you'll learn a little something about what it means to really live. That's right, I live with ALS. I choose to be positive. I choose not to give up. I look forward to waking up every day. I can't wait to be transferred to my wheelchair and sit in front of my computer to start my day. I choose to live every day to its fullest. I choose to live. You can't see this passion because, on the outside, I'm motionless, a breathing statue. There are no signs of life except for the occasional yawn, the ever-present smile on my face, and the moment of recognition when my eyes fall upon yours. ALS rarely affects the mind. I believe having this disease will magnify the strengths and weaknesses of your personality. Therefore, if you were a butthead in your pre-ALS life, there's a strong possibility that you will be more of a butthead after diagnosis. I'm the perfect example. It's fascinating the amount of trouble I can still get into. It's chaos inside this head of mine with untamed thoughts running wildly about like, who will I hunt first when I finally do go to the other side? Why does my dad insist on wearing that hideous comb-over? What makes frosted Lucky Charms so magically delicious? Does this lady who is trying to talk to me know she has a gigantic bat in the cave? Can somebody please get her a Kleenex? My head is bursting with creative ideas. This is why I look forward to working at my computer. I can't wait to see what I'm going to come up with next, a new song, an idea for a new video, or a new short story concept that is begging to be explored. I use iGaze technology made from a Swedish company called Tobii. Yes, the same country who brought you such entities like ABBA, IKEA, ultra-cool names such as Bjorn and Sven, and one mighty tasty meatball. This company has restored a higher morale and a welcome sense of individuality to thousands of quadriplegics around the world. This technology is invaluable to my wife. It keeps me occupied and out of her hair. Without it, I would drive her absolutely crazy. My Tobii allows me to do a bunch of cool stuff. For instance, it allows me to make music. The program I use is the perfect outlet for my musical creativity. It has virtual synthesizers, equalizers, awesome effects, and drum machines. Wow, this is right up my alley as it allows me to tinker with different settings to come up with new, amazing sounds and beats. If you knew how much I adore music, you would see how immersing myself in it is as close to heaven on earth as I can get. I have made 2 videos so far, one for the ALS Association of Arkansas, and one for my song on iTunes. They are both on YouTube for your viewing pleasure. My other creative avenue is writing short stories. What do I write about? Horror. I love horror. It's so intense that sometimes I prefer to read a scary story than watch my favorite sport, football. My intensity puzzles me because it has blossomed after my diagnosis. I could pay a shrink to psychoanalyze my mind only to tell me I have repressed memories of being chased around my house by the Kool-Aid man swinging an X. Or maybe that was the time I got a hold of some bad smoke. Instead, I want to share my active imagination with you. Ghosts, goblins, witches, ghouls, and other things that go bump in the night are topics I'm not afraid to explore. If I am not careful, I can stay up hours thinking about the what-ifs and give myself goosebumps in the process. Yikes. My point for telling you all of this is to show you that I have a very fulfilling life. I focus on what I can do, not what I can't do. ALS is not a death sentence. I still have goals to accomplish because after my diagnosis my dreams didn't die, they only got bigger. Respiratory failure and ALS. In most cases of ALS, respiratory failure is the culprit responsible for patient deaths. Wait a minute, earlier in this book wasn't there a statement made about ALS attacking only the voluntary muscles in the body? This is correct. We breathe all our lives without thinking about it. The act of breathing gets embedded into our subconscious, where it is interpreted as an automatic process. But we can stop breathing when we want to, then do an about-face and start breathing again when we choose to do so. Therefore, the breathing process and the muscles that control it is voluntary. The diaphragm is the muscle which enables us to expand and contract the lungs. As ALS weakens the diaphragm, the patient's ability to breathe is compromised. The first thing I noticed was that I could not inhale as deeply as I once could, which also meant I was not able to hold those long notes when singing in the shower. How was this possible? I just started using the wheelchair a couple of months ago. The notorious death rattle of the disease had come knocking on my doorstep. Once my breathing was affected, I knew this was the beginning of the end. I was terrified. A damaged diaphragm introduces a much deadlier issue. A silent killer that will sneak up on you if you are not careful. Carbon dioxide poisoning, with a crippled diaphragm, The lungs cannot fully contract, and, thus, they will not expel carbon dioxide adequately. The defective blood gas exchange process will cause carbon dioxide to build slowly in the bloodstream and, if not properly treated, will result in carbon dioxide poisoning followed by respiratory arrest. The common symptoms of slow carbon dioxide toxicity are dull headaches accompanied by drowsiness. These warning signs are subtle and can easily be mistaken for other ailments like allergies, a cold, simple dehydration, or the flu. The respiratory therapist will use a pulse oximeter to measure the oxygen saturation of the blood when you visit your local ALS clinic or pulmonologist. A normal reading of 95-100% means your lungs are supplying the proper amount of oxygen to your body. However, the pulse ox reading does not tell the whole story. For example, you may have a reading of 99%, but the carbon dioxide in your blood might be approaching lethal levels. An arterial blood gas test, ABE, will test the blood from your artery to give you not only a more accurate pulse ox measurement but a clear indication of what the carbon dioxide levels are as well. If you are encountering regular dull headaches, especially if they are accompanied by fatigue, contact your respiratory therapist, root, or pulmonologist immediately. Urge them to perform an ABE test. If this is beyond the capabilities of your ALS clinic, make an appointment with a pulmonologist. Some confusion exists over what proper ventilation is for the ALS patient. In the case of victims with a non-functioning diaphragm, putting them on oxygen would be a fatal error. With those who have sustained damage to their diaphragms, oxygen might appease them psychologically, but physically, the blood gas exchange mechanism is still broken. Again, a normal pulse ox reading will give a false sense of security. Then, to properly ventilate a patient with ALS, the diaphragm must expand and contract wholly for proper blood gas exchange to take place. A strategy of preserving the function of the muscles is currently the only course of action in ALS. A method in use today which is designed to delay the onset of ventilator dependence in the ALS patient is the diaphragm pacing system, DPS. This is available to those who are in the early stages of ALS, patients with a functioning phrenic nerve, which controls the diaphragm, and a forced vital capacity (FVC) of 50% or above. The surgeon installs electrodes on the diaphragm or the phrenic nerve, which attaches to an electronic pacing system outside of the patient's body. When turned on, the pacing unit will send electrical impulses to the diaphragm or nerve, which will stimulate it and tell them when to function. The idea is to ration the usage of the diaphragm and prolong its life before the muscle succumbs to the effects of ALS. This device will not halt the progression of the disease. The DPS method is highly controversial in its use for the ALS patient. A recent study conducted in the United Kingdom in July of 2015 suggests that DPS is harmful to ALS patients. One reason for this may be the degenerative nature of the disease. If the phrenic nerve is intact when the DPS is installed, it's only a matter of time before ALS kills it, leaving a useless nerve. Another reason may be stress on the body from the surgery accelerates the effects of the disease. In fact, any trauma suffered by the afflicted body will expedite the process. I witnessed this firsthand. At Christmas time after my diagnosis, I found myself plagued with an impressive amount of pulmonary embolisms, PE, scattered throughout both lungs. Blood clots are another danger the sedentary ALS patient must face. When a person has one PE, they struggle to breathe, and I had numerous. I should have died. My diaphragm was under tremendous strain while clearing the lungs of clots. As a result, my FVC took a nosedive in the following months. Fortunately for me, the one positive about ALS is that healthy lungs remain pliable and therefore will respond to mechanical ventilation. The BiPAP machine or bi-level positive airway pressure supplies positive pressure while the patient is inhaling and negative pressure when exhaling. Additionally, the BiPAP has settings for both the inspiratory and expiratory parts of the breath. As the diaphragm continues to wane, these settings can be adjusted to make certain the patient's lungs inflate and deflate properly. The BiPAP is regulated to patients who use non-invasive ventilation, people who are ventilated through the mouth or nose. They use various attachments to accomplish this, such as the nose pillows, the sip and puff which enables the user to take a couple of breaths when needed, or a mask covering both the mouth and nose. I alternated between wearing the nose pillows for daily use and going to the mask at night. In my opinion, when the patient's FVC drops below 90%, they should start using the BiPAP. Most victims need as much time possible to familiarize themselves with the claustrophobic nature of wearing the mask and the new sensations which come with mechanical ventilation. When you've been breathing one way your entire life, then you introduce a new way of doing it to the brain, your mind will fight you every step of the way, at least for me it did. I remember enduring a constant fear of suffocating in my sleep and the panic induced by the false sense of air hunger my mind kept throwing at me the first few nights I slept with the mask on. My wife put the pulse ox on my finger so I could see I was receiving air despite my body telling me otherwise. I had to repeat to myself, "Relax, I'm getting the air I need, everything is cool." Non-invasive ventilation (NIV) has its limits, especially with me battling a nasty post-nasal drip brought on by chronic allergies. The resulting mucus settled in my lungs, making it tough for me to breathe. Since I had lost the ability to cough up secretions on my own, I had to rely on chest percussion therapy, the cough assist machine, and suction to evacuate the mucus. The caveat with NIV, as I soon found out, was that clearing secretions through my mouth wasn't as effective as I thought would be. My allergies were so awful my family would routinely spend up to 18 hours a day clearing my airway out until I could breathe comfortably again. Air hunger became my detestable companion, and blackouts were a perpetual threat. This was no way to live life. It was time to face the question which confronts every victim with ALS. Do I want to extend my life by getting a tracheostomy? Or should I give up and take the easy way out? My answer was a resounding hell no. Besides, I still had too much piss and vinegar left in my veins to throw in the towel and quit. To trach or not to trach? Extending my life with a tracheostomy did not present much of a dilemma for me. From day one I wanted to fight this disease with everything I had. But it does not mean I did not have my share of doubts. To be honest, I am still apprehensive after one of my acquaintances dies from this disease. I begin to question myself, do these people know something I don't? Am I an idiot for choosing to live in a broken body? Am I a selfish ass for burdening my family with the stresses of ALS? These episodes of self-doubt are always short-lived. They end when I look at my wife and see the love we have for one another. When I wake up in the morning knowing life is such a beautiful gift that I have been blessed with, and I remember I have the imagination as well as the tools to keep producing short stories, my own hideous contributions to the world of American literature. The desire to extend your life is directly proportional to your will to live. I informed my neurologist, a different one, of my decision to go through with the tracheostomy, but the one question I struggled with was how would I know the right time to get it? The doctor was no help. Instead, they were more concerned with instilling the fear of God into my wife and me. The neurologist called us one afternoon. They said my quality of life would plummet. Was my wife prepared for the long days and nights caring for a husband chained to a ventilator through his trach? Huh? I was already at the threshold of hell, being physically exhausted after spending practically every waking moment of the last few weeks trying to clear out my lungs so I could get a couple of unimpeded breaths in. I looked like a ghost from poor oxygenation. My quality of life had hit rock bottom. How could it get any worse? I was willing to take the chance. The neurologist went on to tell us we could expect my life to last another 6 months to a year. What? I did not know they could see into the future. They must have been consulting their magic 8-ball in the office. I have my own, but the most I can get out of it is, it's definitely in the cards or try again. I bet they have the souped-up medical version, and with all those exact answers, that thing must be ginormous. It makes me wonder, how did I miss seeing it with all my visits to the doctor's office? My wife and I were not buying the negative rhetoric. And why the hell were we listening to a neurologist anyway? They should not be giving medical advice on the intricacies of the tracheostomy and mechanical ventilation. That is like going into Victoria's Secret to buy a jockstrap. It just does not work. A couple of days later we notified the good doctor we still wanted to go through with the tracheostomy. My neurologist was not happy about it but went ahead and referred us to a pulmonologist for a consultation. This is exactly what every neurologist should do when asked by an ALS patient about the trach of the vent. Do not pass go. Do not collect $200. Proceed directly to someone who specializes in the workings of the pulmonary system, the pulmonologist. I went through the surgery under general anesthesia and with 0% FVC. Immediately, my quality of life improved. What used to take 18 hours now took only minutes. Cough assist and suction work so much better when you have a hole in your neck that lets you to go straight to the problem. My color came back in my complexion, and I had the first good night's sleep since being diagnosed. I am living with the trach and vent, at the time of this publishing, for over 3 years now. As far as being chained to a vent goes, this is not the case. I go to baseball games, concerts, football games, shopping, and Barnes & Noble. I have traveled to such exotic locations as Perdido Key and the women's restroom at the Floribama. The wheelchair took a wrong turn. Deciding to extend my life with the trach and mechanical ventilation was the best life choice I have ever made. After the tracheostomy, patients living with the trach and mechanical ventilation must become aggressive and advocate for themselves if they want to survive. Hospitals and doctors will not call to check on the status of the patient, because, quite frankly, nobody outside of the patient's support system gives a damn whether the patient lives or not. It's up to the patient to take preventative measures to decrease the chance of serious complications forming in the respiratory system. Choosing a dependable durable medical equipment (DME) provider for the patient's ventilation needs will lay a strong foundation for preventative care. Make sure the DME provider is available 24 hours a day 365 days a year to answer any questions the patient may have and, most importantly, respond to equipment emergencies. They should have a courteous and professional staff of RTS who visit monthly to check on you. If the RT cannot answer your questions, are unable to build a safe ventilation circuit, or they are incapable of troubleshooting ventilation problems you may be having, it's time to find another provider because your life is in danger. No, I am not being overdramatic. Look, we live in a world where we depend on fallible machines to breathe for us, and the last thing we need to deal with is incompetence from DME providers. Trach patients are more susceptible to infections forming in the respiratory tract. Think about it. Our breath enters a hole in our throat that leads directly to the lungs, bypassing the body's natural bacteria filters, the mouth and nose. This is a problem for me because I've lost my sense of smell. I must rely on my foremothers, my wife, sister, caregiver, and RT to tell me when an infection is imminent. They certainly do not sit around me taking turns sniffing my trach like a fine wine connoisseur does when they stick their nose in the glass. That is just gross, but they do know when it's time to see a specialist. Regular checkups, every 6 months, with an ENT doctor and a pulmonologist are also a substantial part of preventative care. The ENT is concerned with keeping the trach site free from infection. The pulmonologist specializes in ventilation and treating ailments in our lungs as they occur. Establishing a rapport with these professionals is a key element to surviving with the trach. There is not much to a pulmonologist's office visit. Today's ventilators allow the patient to download their respiratory statistics and bring it with them to give the pulmonologist an accurate picture on how the patient has been breathing in the past months. On my pulmonologist visit, they ask how I am breathing, if I am experiencing unusual fatigue or headaches, check my vent statistics for any abnormalities, and will swab the inside of my trach tube for a culture. This should be done at every checkup to see if the trach is clear of any harmful bacteria. A chest X-ray and an APE test are done annually. I have my trach tube changed out every 6 months. Though, some patients have this done more frequently. My insurance will only allow 2 trach changes per year because I insist on having my aunt do it. I take a blood thinner to help prevent further blood clots from forming in my body. Consequently, every trach change is accompanied by blood, which is the reason why I choose not to do it at home. I prefer it done under a doctor's supervision. The exact time frame for an adult trach change is not known because guidelines do not exist. My inner Fox Mulder smells a conspiracy running amok in the dull, gray cube farms of America's insurance companies. Could this be a simple oversight, or something a bit more sinister? Perhaps they did not count on adult trach patients having the audacity to live a long time with the trach. If anyone stumbles across guidelines for an adult trach change from a credible source, please let me know. This is something I would love to be wrong about. Over time, the trach tube accumulates bacteria. Delaying a trach change allows the nastiness to increase along with your chance of getting a serious infection. Another thing to consider is the longer the trach stays in your throat, the more the surrounding trachea tissue will adhere to the trach. I remember the first time the ENT changed the trach, I had gone a year and a half without having it done. After the change, heavy suction had to be performed to keep me from drowning in my own blood. Then the doctor showed me the tube that came out of me. It had green, fuzzy stuff hanging off it. I would have hated to examine the substance under a microscope. I am afraid a new strain of bacteria might look at me and wink. Trach tubes are divided into two types, cuffed and uncuffed. The difference is that a cuffed trach, the one I have, has a small balloon around its midsection. When inflated, the balloon forms a seal which blocks air from escaping through the nose and mouth. You must be careful not to overinflate the cuff or abscesses in the tracheal walls will form. If these sores are not treated, the resulting tracheal erosion will eat through the windpipe, causing air to seep out. Furthermore, one of these abscesses may even breach the tissue separating the trachea and esophagus, possibly allowing your stomach acid to leak into the lungs. And it was exactly this the ENT found while changing my trach tube out. The abscess was not a deep wound, but it was severe enough to prompt further examination under general anesthesia. I emerged with a trach tube of a different length to prevent further eroding and giving the sore a better chance to heal. An unfortunate side effect of a tracheostomy is the presence of granulomas. A granuloma is a growth of tissue the body grows in response to infection or a foreign substance being introduced into the body. These growths do not form immediately after the surgery but may fester around the stoma and inside the trachea in the weeks following the operation. These can grow to a size that will affect the airflow in the trach tube, and, in some cases, the blockage may get so extreme that urgent emergency care is needed. If you have a granuloma, let your ENT know. Let their expertise work for you. They will evaluate your growth and determine if surgery is required to remove it or if it can be treated with medication. Ignorance is prevalent in our world of trachs and vents. A large part of this is due to the absence of universal guidelines for the adult trach patient. This is why you must start out and remain aggressive with your trach care. Do not make the same mistakes I did. Passive respiratory therapy. Landing in a doctor's office or hospital with a medical problem that could have been prevented is not high on my bucket list. Good respiratory therapy habits can help me stave off ailments which could easily escalate into a life-threatening condition. The respiratory therapy I do at home is no guarantee against the bacterial infection or virus biting me in the ass someday, but I'm a big believer in making your own luck and am convinced my therapy will soften the blow of the illness. My passive respiratory therapy begins with protecting the lungs from disease and viruses by immunization. I always get an annual flu shot. Because the influenza virus mutates, the vaccine is not 100% effective. However, doctors say if I do contract it, having the shot will lessen the severity of the infection. I received a bacterial pneumonia vaccine when I was diagnosed 5 years ago. This immunization shields me from the most common bacterium. I am all for doing whatever it takes to increase my chance of survival. My wife does trach care twice a week. She inspects the trach site and cleans around the stoma. Her examination includes monitoring the small granuloma growing out of my trachea. She is concerned with any significant change in size. Fluid, whether it is blood or mucus, always accumulates around my stoma and must be cleaned off. If it is not, it will become entangled with my facial hair, forming a stinky mass of hair and dried blood or mucus that is a breeding ground for unwanted bacteria. To prevent this, my wife shaves around the stoma once a week while cleaning the dried gunk as needed. Cuff trach tubes come with an inner cannula. This is a small tube which fits inside the larger, outer trach tube. The sole purpose of the inner cannula is to serve as an emergency release when a plug occurs. In theory, removing the cannula will unclog the patient's airway. My wife and I have never put this to the test. We've always used the cuff assist to get rid of the plugs. Since the inner cannula rests inside the trachea, it also needs to be exchanged with a clean one on a regular basis. We change my inner cannula out at least twice a week. It's swapped out every day when I am sick. For those of us who use mechanical ventilation, hygiene does not stop at the trach site. The circuit tubes through which we breathe must be disinfected every week. Moisture from our breath and in-circuit humidifier produces the warm, wet environment that bacteria love to flourish in. Robin alternates between two sets of circuit tubes each week. The set that is out of operation is soaked in Control 3 disinfectant solution so it's clean and ready to go for the next week. All circuit tubes should be replaced with new ones every 3 months. As I stated earlier, airflow with the cuff trach bypasses the mouth and nose. Not only do these serve as our body's natural filters for the air we breathe, they also act as a humidifier, warming and moistening the air for intake by the lungs. The cold, dry air blowing out of the ventilator will dry out the lungs, thereby raising the probability of plugs forming. Think of these as boudres in your lungs, but they are larger and extremely dangerous. To counter the development of plugs, artificial humidity becomes a necessity for trach patients. There are 3 methods of delivering artificial humidity to the trachea, with the first being the use of a room humidifier. Although the device will help raise the ambient humidity, which will indirectly improve conditions in your airway, it should not be deemed as the solution for the humidity problem. Regular disinfecting must be done on room humidifiers to prevent the buildup of fungus and mold inside them. The next delivery method is the wire-heated, in-circuit humidifier. Ventilator air passes through the heated, moist environment of the humidifier and onto your lungs. I prefer this device because I can control the amount of heat it produces according to my needs. For example, if condensation develops in my vent tube, an indication that the humidifier is generating too much heat, I will cut back on the power. If my secretions are too thick or I feel like I am too dry, I will kick the humidity up a notch. Do not use ordinary tap water with this type of humidifier. Only distilled or sterile water should be poured into its reservoir. Again, like everything else with the trach ventilator circuit, it's important to disinfect the reservoir every week. Use extreme caution when the in-circuit humidifier is in operation because condensation will form in the vent tubes. When an excessive amount of water collects in the vent tubes, the patient will sound like they are taking hits off a bong pipe or blowing bubbles in a glass of milk. Hopefully, their ventilator will start to alarm as well. When this happens, always disconnect the vent tube and empty accumulated water into a container. Do not reuse this wastewater. Never, under any circumstances, let the water drain back into the patient's airway. As we all know, when water or any liquid is introduced into the lungs, it does not work out well for the victim. Pay attention. The third and final method of adding artificial humidity into the circuit is the heat moisture exchanger, HME. Also known as the artificial nose, this little gadget attaches to your vent tubes to become an in-circuit humidifier. The HME turns the heat from your breath to humidity. Its small size makes the apparatus portable and easy to travel with. I use it when I am traveling long distances. Some disadvantages of using the HME are that the power cannot be adjusted according to your needs, and these must be discarded every 2 or 3 days. During illness, it's recommended to change them out every day. The problem is insurance only pays for a set number of HMEs a month. If you use this method, keep careful tabs on your inventory. Warning: never use the wire-heated humidifier and the HME at the same time. This will create too much humidity, with the surplus moisture working its way into the sensitive electronics of the ventilator, causing it to fail. Active respiratory therapy. The sedentary nature of ALS puts the patient especially those who are in the late stages of the disease, at a higher risk for developing pneumonia. Because of this lack of movement, pooling of fluid in the lungs becomes another potentially life-threatening obstacle the victim faces daily. Chest physical therapy (CPT) can help with this problem. It consists of a series of movements including various percussive techniques, clapping or tapping of the hand on the body, designed to break up mucus and induce drainage of this fluid out of the lungs. For a guy who cannot talk on his own, one would think that it's easy staying out of trouble. I wish this was the case, but I have developed a knack for drawing the ire of my wife's wrath. How can a fully paralyzed, lovable man wreak more havoc than he did before he contracted ALS? I know, right? The point is that since I am constantly on my wife's bad side, do I really want to give her the opportunity to exercise her kid frustrations in the form of percussive CPT? I do not think so. Some things are better left under the control of machines. My CPT device employs the concept of high-frequency chest wall oscillation, FQ, to accomplish much of what manual CPT does. The execution of the machine's job is designed around an inflatable vest of which I wear on my chest. It hooks to an air compressor via two hoses. Controlled air bursts shoot out from the compressor, through the hose, and into the vest at high frequency. This results in a rapid agitation of the chest wall. My routine consists of two 10-minute cycles, one at 12 Hz, and one at 17 Hz, 2 times a day. Of course, if I am battling a chest ailment, the instances of CPT will increase. It's important to expel the loosened mucus following a round of CPT with a cough assist session. If you are able to cough effectively on your own, great, but if your last FVC measurement was less than 100%, the disease has begun to destroy your diaphragm. I highly suggest you start using the cough assist machine to help you eliminate secretions completely. In my opinion, the cough assist is the one crucial machine that every vented ALS patient must have. It has saved my life more than a few times by dislodging plugs and giving me emergency ventilation when something went wrong with my ventilator. In addition, my usage of this machine on a regular basis has helped me ward off serious chest infections. One thing that caught me off guard was when I had my feeding tube placed. The stomach had risen in my abdomen to the space previously occupied by the lower lobes of my lungs. They had decreased in size significantly. ALS had actually squeezed the breath out of me. I am not saying this will happen to anyone with the disease. As we all know, ALS affects every person in different ways, but this leads to another benefit of cough assist therapy. It hyperinflates your lungs, which allows them to expand and contract completely. Mechanical ventilation breathes for the patient within preset volume limits. The patient has lost the ability to take deep breaths. Compared to normal breathing, mechanical ventilation is shallow. Long-term periods of this soft breathing without permitting the lungs to expand and contract fully with cough assist therapy can cause partial or total collapse of a lung, a condition known as atelectasis. The cough assist machine inflates your lungs using a large burst of air on the inspiratory phase of the breath and will pull out debris on the expiratory part. You are connected to the machine through a hose and mask which fits over your mouth and nose pre-trach. If you've had a tracheostomy, your DME provider will furnish a trach tube adapter connecting the trach to the hose. It takes a few sessions to get acclimated to the power of the device. The first few times I used it, I thought my eyes were going to explode out of their sockets like those unfortunate characters in cartoons. Be careful, because if your settings are too high, serious lung damage can occur. So, start with the settings at 0 and work your way up to the levels you can tolerate. I use the cough assist in times of stress when my respiration is too intense for my ventilator to keep up with. This happens frequently in football season. It's my favorite time of year. I love it all: high school, college, and pro, Canadian and American. That is right, I said Canadian football. What happens is my favorite teams will not play as I think they ought to, or the game comes down to the last play. My vent starts alarming, out comes the cough assist, and then my wife threatens to turn off the game if I cannot get it together. It's like clockwork. This happens every single time. I told you I stay in trouble. Seriously, though, just remember if you feel anxious about your breathing, there's nothing wrong with taking a few deep breaths off the cough assist. Having the power of the cough assist machine at your fingertips places the burden of great responsibility on your caregiver. You will be astonished at how a simple, gooey ball of lung snot turns into a weapon with deadly accuracy after a little charge of compressed air gets behind it. This demonstrates Sir Isaac Newton's third law of motion perfectly. For every action, there is an opposite and equal reaction. One thing for sure is you will finally be rid of that bug problem your spouse is always complaining about with the steady hands of your caregiver. You say you have a chest cold? Well, that is bad news for the squirrels who keep getting into the bird feeders in your backyard. Beware, if your plugs are hard enough and your caregiver loses control of the hose, they might end up taking out a window or two. There is always some residual mucus left over after my cough assist sessions. My caregiver uses the inline suction to dispose of the lingering debris. The trachea and bronchial tubes are extremely delicate. You can easily nick a blood vessel with the suction tube, causing the airway to bleed. This has happened to me before. The episode was so severe that it resulted in an emergency room visit. Because suctioning is so invasive, I prefer cough assist therapy to suction for clearing my secretions from the trachea.